Good afternoon to our participants in East Africa. Good evening to Stephanie in Australia and to our participants in New Zealand or the ones who are in the Asia Pacific side. And good morning to our participants in South Africa. So thank you for making time to join this talk. This is going to be our 187th Fireside chat. And we're going to look at a very interesting topic. It's on matters nutrition. As we all know, nutrition is a very key pillar on matters kidney disease and management of kidney disease. So our topic for today will be on dietary counseling in kidney disease. I forgot to introduce myself. I'm Dr. Yuri. I'm the Country Medical Director at HN Kenya, and I'll be your moderator for this session. So our guest speaker for this talk is Miss Stephanie Notaras. I hope I did justice to the name. I'll just say Notaras for now, so that I don't get tongue twisted. So just a bit about Miss Stephanie. She is an accredited practicing dietitian, the host of Nutrition Counselling Corner podcast, a published author, and the owner of the online dietitian counseling skills practice. She has a master's degree in counseling and helps dietitians around the world improve their counseling skills for better client outcomes and retention. Stephanie has developed, evaluated, and published a counseling skills framework for dietitians to apply to their practice. She has been practicing dietitian for over 14 years, specializing in renal nutrition, renal service development, and advocating for better person-centered care within renal health services and practices. She brings a unique perspective to how dietetics and counseling can be paired effectively within your scope of practice to enhance the client experience and retention, optimize health, and reduce disease progression. Stephanie is also undertaking a PhD into the impact of dietetic intervention on kidney disease progression and behavior change strategies that can influence client outcomes. Her research has won the prestigious Nutrition Research Award from the Australia-New Zealand Society of Nephrology. She also guest lectures on counseling skills for dietitians at Australian universities and has presented on this topic to several international dietetic associations, including the Academy of Nutrition and Dietetics and the British Dietetic Association. She was awarded the Allied Health Award for Dietitian of the Year in 2024. So a very impressive CV, and looking forward to this talk from Stephanie. Over to you. The floor is yours, Stephanie.
Thank you so much for that lovely introduction. I'm really excited to be here. I'll just share my screen and we can get started. Great. So today's presentation is going to be on dietary counselling in kidney disease, specifically around how you talk to people about nutrition and how can we get people that are living with kidney disease more empowered to make use of nutrition and specific eating behaviours to help them with managing the condition that they're living with. So a little bit about me. I think that the introduction said a lot about what I was going to say already, but I am a practicing dietitian from Australia and I specialise in kidney disease with a master's in counselling and undertaking lots of research through my PhD into looking at what impact dietetic intervention can have on time to dialysis, kidney disease progression, and also recently looking at the client experience with changing their eating behaviours and trying to find out what they do experience and why they find it so difficult to make changes. And so today, the presentation that I will be talking to you about is going to be very much a summary of what I have learnt from my practice as a renal dietitian for all these years, from my published studies, from other published studies that are available, and from the curriculum that I was very honoured to learn in my Masters of Counselling. And so today what I'd love to go through with everyone is giving you a bit more of an outline and a better understanding of what the experience is for people living with chronic kidney disease, both non-dialysis dependent kidney disease and dialysis dependent, what clinicians tend to go through as well when they are trying to educate and empower clients to change their eating behaviors. And then I want to go through a little bit of the theory on what does it take for someone to really change their behaviors around health, whether it's eating behaviors, medication adherence, fluid adherence, talk through some of the common mistakes we generally make as a kidney health professional community, and then some very specific behavior change strategies that you can walk away with and start using with the next patient that you see. And we'll also have some time for some questions at the end of the presentation. So when we look at the research around the patient experience, almost every single study that has been done on anyone with kidney disease that is either on dialysis or not on dialysis, but predominantly a lot of the research is on people that are on dialysis, they find it really hard to follow the diets that we are prescribing. And arguably, the diets that we are prescribing to people that are on dialysis are probably one of the hardest diets to follow. So adherence is often quite low, both with fluid recommendations and also with eating behaviors as well, such as trying to follow low potassium, low phosphate, appropriate protein and an appropriate energy type of eating plan. So people do have a very hard time with change. They find it a very confusing process to work out, how do I take all this knowledge? How do I remember all this knowledge? And then how do I apply it to my life while still being able to enjoy the social aspect of eating, enjoy cultural foods, and not feel so isolated. And so they're the main factors that people have the most difficulty with, that leads them to not being able to adhere to a lot of the recommendations. And another issue that comes up a lot in the literature is that there is conflicting information that is given across health professions. So sometimes within the same team, the nephrologist versus the kidney nurse or the kidney dietitian might be giving different recommendations, which makes it very hard for someone to follow. So we've got that patient experience when it comes to eating behavior change. And then when we dig even deeper in the research, the main themes that come up for people that are either new to dialysis or have been on dialysis for a while is that there is a lot of overwhelm that is happening while people are undertaking this treatment. It's a very complex regime, and it makes it very hard for them to have the cognitive capacity and the space to be able to think about eating behavior changes as well. They find it very confusing with a lot of conflicting information available both online but also within different health professions in the kidney disease space. And they find living with dialysis from probably about stage 4. So as soon as the eGFR hits about 20 and under, we see a lot of patients starting to complain about a lot of physical symptoms and emotional symptoms that make it very hard for them to cope and adjust to the disease process. And it is a very big adjustment with major life changes that's taking them away from things that they usually would be doing and putting a lot of their time into a life-saving treatment. And so what we've noticed a lot in the literature and within our experience with renal patients in Australia especially, but the research is worldwide, that all of these extra challenges that just come from living with CKD and being on dialysis make it very difficult to also be able to take on a lot of eating behavior change. Because when we think of eating behaviors, while nutrition is a science, eating is a behavior. So there is a lot of psychology and counselling that goes behind someone successfully changing their eating behaviors when they're living with kidney disease. And so what you see over time is the people that find it the most difficult to adhere to the diet are usually the ones that are the most overwhelmed, the most confused, and have a lot more social issues going on for them, making it harder for them to adhere to the diet. So the lack of adherence is sometimes part of their coping strategy. So the avoidant behaviors of doing what they might be recommended to do with their fluid and their eating recommendations is a coping mechanism to deal with a lot of the overwhelm that they are experiencing. And so when clinicians, especially kidney health clinicians, are trying their best to educate people on eating behavior change and having the nutrition patterns that are going to help them to either reduce disease progression and delay dialysis, or help them reduce dialysis complications and for dialysis to work better once they're on it. When we look at that clinician experience, there are a few things that are quite widespread across the literature. Is that it can be very frustrating when clients aren't changing once you have educated them. And often, as health professionals, we're not very sure how to counsel, but we're very well trained in educating and being able to provide information. But when it comes to eating behavior change, people are going to have a lot of barriers, both personal barriers, emotional barriers, and physical barriers to changing their eating behaviors. But there is a lack of behavior change training that is happening within most of the professions. So when we look at medical officers, nurses, dietitians, and other allied health, we tend to walk away from our training with a lot of the science, a lot of the what to change, the information, the gold standard of treatment, but we don't often walk away with the skills of how do we communicate with people to empower them or to help them find their motivation for change. And often in dialysis units and kidney care teams in general, a lot of us are under-resourced, making it harder to be able to access training and then implement it on the job. And so where does that leave us? What do we need to know in order to really help our clients and our patients be able to get the best health outcomes possible when they're living with kidney disease? We've got to start understanding the stages of change and what it takes to really change behaviors. So this is the trans theoretical model of health, where it categorizes people's readiness for change into 6 different categories. And a lot of you may have already seen this at some point within your career. And so most health professionals that will be very, very well equipped to counsel and educate and consult people that are in the action stage of change. This is where knowledge and information and a practical plan is what most people need when they are in the action stage of change. And this means that they've already developed a very big motivation for change and they're ready to go and change whatever is necessary. But most often what we see in the kidney disease space is that most people are sitting at the top. Most people are sitting in contemplation. And so if I was to quickly summarize the different stages of change, pre-contemplation would be where someone with kidney disease would say to you, I don't really think I need to change. I'm okay the way I am. My diet is fine. Contemplation would be when a patient might be saying to you, I know I need to change, but I'm just not ready yet, or I know what to do, but I'm not doing it yet. Preparation is when they have started to build more motivation for change and they're getting ready. They want to change and they're planning to do it very soon. Action is when they're making the changes. Maintenance is when they've been doing them for a minimum of 6 months straight. And then relapse is when there is some type of event or setback where people revert back to their usual eating behavior patterns, whether it's going back to eating foods that are higher in salt or foods that are higher in potassium when they've been diagnosed with multiple episodes of hyperkalemia, and so on. So the literature with kidney disease tells us that the majority of people are sitting in the contemplation stage of change. And what makes this stage very interesting is that people that are in the contemplation stage of change don't respond that well to just education, and they often need help from their health professionals to get ready for change and to find their motivation for change. And so this leads me to wanting to talk to you about what does it take for someone to change their behaviors. And there are multiple social theory models that are available. And if we look at all of the multiple models that are available, there are 3 concepts of behavior change that are found in almost every model. And that is that someone has to have a very strong reason for change, a very strong motivation beyond just it might help dialysis work better. They need to have some type of reason that is value driven, where they feel it's very important. And if they don't change, there's a significant risk to themselves and to their relationships. When someone has established a motivation for change, then they've got to move into developing urgency. I need to do this right now because there is a risk that if I leave it for too long, something negative might happen, or I'm not going to get the positive outcome that I'm hoping for. A lot of people get stuck with building urgency. If you consult people that are not yet quite ready for dialysis, but are getting ready for it, and they appear motivated, often the urgency is what they struggle with, because they're living with an invisible disease that might not give them as many symptoms until they get right to the end of needing dialysis. And so urgency tends to be very low, and they think they've got a lot of time where they don't need to start making changes. What tends to improve in terms of urgency is right in that pre-dialysis period. That's when we see patients really starting to think about what can I do to avoid dialysis, and urgency increases. And then once they're on dialysis, it tends to decrease again, because the whole motivating factor behind them changing their eating behaviors was around avoiding dialysis. So once they're on dialysis, they need to go back to trying to find a new motivation for them to even bother to adhering to all the recommendations. And then they also need confidence. So once they've got motivation and urgency, they need confidence in order to change, a belief in themselves that they can do it and that it's going to make a real difference to either their longevity, their health outcomes, and to the quality of their relationships if they stay healthy, or as healthy as possible. And so how do we get people empowered for change? Because this can be quite tricky. When we look at the motivation literature around eating behavior change, we can't really we can't motivate people. We can't transfer motivation from one person to the other. But what we can do with a set of strategic questions, we can help people build these 5 areas, these 5 core concepts to help them make changes successfully and for the long term. So the first one really relates to what I was talking about before around them building a very strong motivation for change, building that importance of what this change could do for their life. Number 2 is about acquiring knowledge. Number 3 is believing that you have choices. So when people are told what to do and almost very didactically, you need to do this, there's no other choice, they tend to become a little bit more defensive. So believing that they have choices is going to be part of them feeling more empowered to change. They also need to, we need to help them strengthen their abilities and their confidence with very practical plans and strategies that are going to be matched to the person's capacity for change, not just their health condition. So what we see a lot of health professionals doing, and I've definitely done this in the past as well before I went into doing my Masters of Counselling, is I used to provide a lot of education based on kidney disease. Whatever someone needed to know, I'd be very keen to let them know and to support them through the journey. But whilst you've got to match your education to someone's condition, you've also got to stage it and match it to their capacity for change, because everyone is going to have a varying capacity to change. Someone with more support, family support at home, is going to have possibly a larger capacity for change. Someone with less physical symptoms might have a higher capacity for change. Someone who is in a lot of pain and doesn't have a lot of support and has a lot of gastrointestinal symptoms from being on dialysis is going to have a lower capacity for change. So really taking that education and making sure that it is tailored to whatever is going on for the person at the time, and then them getting support to keep implementing it. What we see from a lot of the research studies that we have available to us is that when clients are getting the support from their nephrologists, from their nurses, from their dietitians, they're often engaged in making changes and getting very positive outcomes in terms of blood pressure control and electrolyte management control and edema control as well. But what we often see is once the support gets taken away, it's very hard to maintain those behaviors without support. So getting support and having that long-term available to patients is also quite crucial to keep the health outcomes maintained. And so some of the common shortfalls that we do that by mistake means that we don't meet those empowerment requirements for people is that often in healthcare we are we emphasize a lot of the risks and complications of not following the recommendations, which is important, but it's often very fear-based. And what that means is that when people are motivated by fear rather than something else that is going to be what I call more value-based, and I'm going to explain that in a little bit more detail on the next few slides, is that fear is a very short-term motivator for change. So you might see a little bit of a change, but then people are often revert back to their older eating patterns. We often give too much information in one setting, and this causes overwhelm to people. The moment that someone is overwhelmed, it almost cancels out them feeling empowered, which makes it a lot harder for them to make changes and to make decisions around eating behavior change. What the literature has said to us, and this is probably one of the strongest themes that keeps coming out from any client experience literature and also from my own studies that have been published and are about to be published next year, is that whenever there's a lack of personalization to any of the recommendations that are provided to people living with kidney disease, especially on dialysis, it negates the possibility of eating behavior change, and it makes it very hard for them to engage in it because they don't feel like it's customized to their needs. There's also a very big focus on building knowledge, which is very important. But if I was to go back for a moment to how we help people get empowered for change, building knowledge is only one out of the 5 principles of helping your patients get empowered to change their eating behaviors. And so what you want to be focusing on is knowledge, yes, but also their motivation and their confidence to change. Because most often what stops them from from participating in more health promoting behaviors is a lack of confidence in their own abilities to either start something or keep it up, and not collaborating enough with the clients to find out what capacity they have for change. And so you can match your interventions to their capacity. And so what do you do instead? So I want to go through 5 key things that you can do that is from my own behavior change counselling model that I've put together and evaluated and published for eating behavior change. And it's an eclectic combination of lots of different counselling and psychological theories that will meet those 5 principles of helping people get empowered for change, especially if they're living with kidney disease. And so I'm going to go through all of these 5 behavior change strategies in more detail. And these are strategies that whether you are a dietitian, a nurse, whether you are a nephrologist or any other type of medical officer that is interacting with people that are living with kidney disease, you can be using these strategies not only for eating behavior change, but to look at medication adherence as well, and helping people become empowered to be more adherent with that as well. And so let's go into the first one in a bit more detail. So one thing that's really important is to start exploring people's personal goals in more meaningful ways. So often we might be asking people or exploring their goals as to, you know, what would you like to get out of today's session? What do you need to know? And often that keeps things very surface level and becomes very hard for people to develop the deeper type of motivation, which we refer to as intrinsic motivation. Intrinsic motivation is something that is very value-based, where for someone to be motivated to do something, it needs to mean that their life is going to get significantly better from it, versus a fear-based motivator where they're just scared of an unhelpful outcome happening. And so when you're able to ask questions to your patients around where they'd like to see their health from in 6 to 12 months from now, and you can feel free to alter this timeline depending on where your patients are at and their prognosis and whatever might be going on for them, you might change that question to what would you like to achieve with your health? You're always going to get the most surface level answer coming up first with this question. But going a little bit deeper with this and finding out why it's important to them to achieve and what impact this might have on their life and their relationships, it starts to allow them to think more deeply about why engaging in certain eating behavior change is going to be very helpful. So instead of asking them where would they like to see their eating behaviors in 6 to 12 months from now, you want to be asking them where they would like to see their health, and then using eating behavior change as the vehicle to be able to get there. But there needs to be a very strong reason for them to want to change, and they need to be telling you that. One of the biggest principles in counselling that they really emphasized a lot in my Masters of Counselling was that people will believe something when they hear themselves say it. So if they're the ones being able to say it to you, they are more likely to be building their intrinsic motivation for change. The second thing that you can be doing quite in your consultations is starting to explore their views and opinions on eating behavior change, what they already know and what they've already tried, along with exploring barriers and challenges that they are experiencing. And this is very important, because when you start getting them talking about what they think about change, or what might be worrying them about change, if they've tried something before and they found it very difficult, or there was a negative outcome from it, they found it really difficult to socialize with their family and friends because they were on a special diet, then they're barriers that are going to keep coming up for people. And people living with kidney disease have a lot of challenges to eating behavior change. And when you're able to get them talking about it, what we've found is that there's less resistance to them hearing what you want to say to them once you've been able to explore this with them first. Also, the more that you understand what they're finding really difficult about changing, then the better you can match your interventions. And so the solutions that we provide as health professionals can only be as good as how well we understand the problems that our patients are going through. Because the moment that an intervention feels matched for the client, the moment that they feel that it's been personalized, they're more likely to go ahead and engage in it in the long term. And so this also allows you the opportunity to provide a lot of empathy and validation to what they are experiencing and the challenges that they are having at the moment. What we've been able to see through the literature is that when patients feel like they are getting empathy from their kidney health professionals, resistance to change and that universal anxiety that exists when people are talking about eating behavior change, it starts to reduce, and we see them getting more into problem-solving conversations because you're helping them better understand the problems that they're having, and they're feeling heard and seen by you. And so studies have shown that the more empathic statements that clinicians can use when their clients or patients are struggling to change, the more easier patients find it to actually problem solve, which really is quite telling for the importance of that therapeutic relationship that we develop with patients that are living with kidney disease. The third thing that is going to be very important to go through with your clients is how to explore their expectations for change. So usually when people are wanting to change their eating behaviors, they also want the results to be really quick. If I start something today and I put all the effort in to do it for a week, I want to be able to see an outcome by the end of the week. But that's not how eating behavior change works. Often it takes at least 3 months to see the physiological improvements that can happen from nutrition changes. They may see some immediate improvements, in electrolyte, in certain electrolytes, but often it takes time. And so exploring people's expectations for change and their relationship with change can be very beneficial. If they were to make these changes, you could ask them, how long will they give themselves to try this out? In order to get the outcomes that they want to get? When are they most likely to give up? What is most likely to help them keep going? And whenever I've asked these questions to patients of so many different cultural backgrounds, where I've worked with one of the most multicultural areas in Sydney, universally the most common answer is, I'll keep going if I see results. And so this is why it's important to get people talking about their expectations for change, because if they are unrealistic, you're going to need to use your insider knowledge to let them know what they can be expecting. And so this brings me to strategy number 4, which is beginning to share your insider knowledge. This was a concept, a theme that came out of one of my published studies with patients living with kidney disease about to start dialysis, and what they felt like they needed from their health professionals. And that was for us to share our insider knowledge more frequently, so they can have better expectations of the journey. Whenever someone is starting a new medication or they're about to engage in more eating behavior changes, understanding what the process is going to include and entail is very important for them to keep going and for long-term success, because it widens their window of tolerance to be able to make changes without giving up. And so what this might look like with sharing your insider knowledge to your patients is letting them know that, yes, these are a lot of recommendations that we're going to go through. These are not going to be easy. If you find yourself struggling, this is very common. It is not a matter of if you're going to struggle, it's a matter of when, and you're not alone. Most of the patients that I've seen living with kidney disease that have been successful in being able to eat in a pattern that is health promoting for them being on dialysis, they aren't the ones that didn't struggle, but the successful ones are the ones that struggled and assigned the most helpful and correct meaning to it, that it's actually part of the process. It's not a sign for you to give up or that you're failing. It's a sign to lean in and get more support from the health professionals that are there to help you. And so when you are sharing your insider knowledge, let them know that the first 3 months are often the hardest. And if they can persevere and not give up, and they get to the 3-month mark, they're more likely to see results, and they're more likely to build on that momentum to wanting to keep up the change, because they're more likely to see their treatments going better, and if they're not yet on dialysis, delaying the need and the onset of dialysis. Explaining to them the importance of perseverance, of giving themselves at least 3 months to try all of these changes without giving up or prematurely evaluating whether they should be further or not in terms of their health outcomes, and really explaining your role. What is one of the most common reasons for people not coming back to see a kidney health professional, especially a dietitian, is that they feel like they got all this information and they couldn't action it all. So what's the point of going back, because I can't cope with more information? And so if you can explain your role to clients and patients, that you are here to teach them what to do, but you are also here to support them with how to do it, because eating behavior change is difficult, then they are more likely to come back, talk to you about their struggles, and most likely overcome them so they can get better health outcomes from following certain eating recommendations. And then this brings me to the last point that I want to talk about with you, and that is when you are giving recommendations to your clients, for them to be extremely collaborative. So you are getting the patient as involved as possible. You might be the one that's giving a lot of the recommendations, but where you want it to be collaborative is to be asking people how many things can they manage between now and the next time that you see them. How might they go about it? What support do they need? And so on. So you encourage that collaborative discussion. You also want to be starting to really tailor and prioritize your education. With kidney disease, it is so easy to sit there and educate for 2 or 3 hours in that first appointment. And you want to do your best to avoid that, because people will get very overwhelmed. And one strategy that I've incorporated into our renal clinics is called the client or patient roadmap, where I would go through with patients all the things that we are eventually going to cover during our time together, so they are aware of what it's going to look like to work together. But then you start slow, you narrow things down, and you work on one thing at a time. This can be really tricky with very complicated cases, because if your clients have lots of issues going on, it's very tempting to give them all of the solutions to just manage all the issues, but they will get very overwhelmed. And so you want to be prioritizing interventions. So you're not giving more than 3 or 4 interventions per session, and for your recommendations to be very clear, to not have any room for ambiguity. So your client, so things like if someone says to you, oh, can I eat bananas? Can I eat this fruit? Can I eat this vegetable? And your answer is in moderation. That creates ambiguity for clients. What's actually better is to say to them, look, let's have a look at your blood test results. Let's say your electrolytes are looking like they are normal right now. Let's decide to include this food once a week or twice a week in your diet. Let's test your bloods in 1 month. That's going to tell us how much you can manage. And then we'll be able to work out whether we can titrate up or titrate down. So you take a very systematic view on the recommendations, so people are very clear, because the clearer they are, the less confused they get, and the more likely they are to action your recommendations. The last thing that I would just want to touch on is preempting the struggle that people are going to have. So once you give recommendations to your clients, talk to them about what they think, how confident they feel that they're going to be able to manage all of this. How are they going to go home and implement all of these things? And if, like, what can they see getting in the way? What could make things difficult for them to action? Some people are going to turn around and say to you, I think I'm going to have some difficulty. This seems like it's a lot, or I feel very stressed at the moment, or life is going to be very busy over the next 2 or 3 weeks. And some people might say to you, nothing, I think it's going to be okay. Even for the people that say to you, it's going to be okay, what I would recommend is going that one step further and saying to them, let's say something unexpected happens. How are you going to manage these 3 or 4 things that we have discussed today? And this gives you an opportunity to talk to clients about, out of these 3 or 4 things that you're recommending, let's say life gets very stressful or busy and they don't do much of it. Can you ask them, well, what's the one thing out of these 3 things that we've discussed today, that if life gets too hard and you can't do all 3, what's one thing that you can commit to with certainty? So then if things do get overwhelming and stressful, they're going to be able to come back to that one thing, because they made that decision with you when they weren't stressed, when they were in the session with you. So when they do get stressed and decision making is a lot harder, the decision has already been made for them. And it also lets them know that even if they're doing something, it's going to help them to move forward and towards the health outcomes that they're hoping for themselves. And so when you are looking at applying all of these strategies, one of the things that I highly recommend is taking one strategy at a time. Otherwise, you as the clinician is also going to get overwhelmed trying to do all of these things at once. So pick one strategy, stay consistent with it, and then perhaps keep adding the next strategy and the next strategy every 2 to 3 weeks as you're practicing. I also just want to note something about time, because time is the #1 barrier to clinicians being able to practice this way. And this is very clear from the literature as well. Most people don't counsel their clients, they go straight into education. And because it's much quicker to just tell someone what to do rather than collaborate with them and use the empowerment model. So what you will notice is that initial sessions tend to be a little bit longer as you are using these strategies, because you are still learning yourself and trying things out, but you save time in the future because your review sessions are less, and sometimes you actually need less of them as well. And always come back to the purpose of using these strategies as the clinician, which is this is going to help to improve patient outcomes in the long term. And so some take-home messages to finish up with: understand your influence. Even when your clients are struggling to change or they're not quite ready for change, you can really have a strong influence on getting them ready for change and getting them confident to do things differently. Really begin exploring with them very meaningful outcomes about their life that could come from having a better adherence to nutrition recommendations. Expect that they're going to struggle, that there's going to be challenges, and expect partial adherence, because partial adherence is so much better than no adherence at all. And remember to share what they can expect from the journey, what's normal, because then they feel less isolated in their experience, and prioritize your recommendations. And if you need any more support beyond today's webinar, feel free to get in contact with me with your questions, and you can also access my podcast as well, where I release lots of nutrition counselling strategies and episodes quite frequently. Okay, thanks everybody. Should I stop sharing my screen so we can have some questions? Is that the way you usually do it, or do you want me to keep the screen shared?
You can keep it on.
Okay.
But thank you, Stephanie. That was quite an enlightening talk. And thank you for also sharing the take-home messages. I think I can add some that I learned through the talk. Let's avoid being passive. Let's be active. I think that's an important one. And then also to avoid ambiguity. So we need to be very clear. We need to curate a plan that is tailored to patients, not just to paint everyone with the same brush. I think that's very important to look at. And I think we keep on learning and improving whatever we do. So that was a really good one. I want to probably open this session now to questions from the participants, but probably I can start from probably myself, because I know we are kind of moving into the festive period, and I was just interested looking at when you're sharing the stages of change, and I'm more interested on relapse, because I get a lot of patients having relapse, even the ones who have been on the maintenance phase for more than 6 months, doing really well. And then when you get to the festivities where it's all about merrymaking, and they're invited to parties and a lot of, I think sometimes even weddings and all that, so we get a lot of relapses. So when it comes to January, we get really poor outcomes. And most of the times I'm just holding my breath, waiting for January to see patients coming back with hyperkalemia, fluid overload. And it's quite challenging, I might say. I don't know whether you can give us a few tips on how to manage relapse, because I think once we start with one relapse, it just becomes a vicious cycle. Yeah.
Absolutely. And I think that what's really important here is to have some proactive strategies with relapsing, and then some reactive strategies of what you do when your client has actually relapsed. So let's say with the festivities coming up, if you are seeing people before the festivities, actually talking to them about how they're going to manage it. So preempt that these festivities are going to make it more difficult for them to follow their usual recommendations. So you can ask them questions around how are they going to manage it, what are they planning to do, how can they still enjoy themselves safely? Because one of the most common reasons for relapse for people that are on dialysis or end-stage kidney disease is that they're so desperate to enjoy themselves and to just forget that they've got kidney disease for one day, that they just go and do whatever they need to. And so there's a psychological component to it. But if you can talk through them, with them, how to mitigate going and having such a full relapse or setback, but how can they enjoy themselves safely? They'll think about it beforehand. So when they are at the festivities, they might have better strategies in place because they've already talked to you about certain things, whether they, have a little bit of this, a little bit of that. They've thought about it beforehand, so they don't have to worry about making too many decisions on that day. But let's say you haven't had a chance to preempt it. The most important thing you can do once someone is clinically stable, their hyperkalemia is better, their fluid overload is better, you sit down and you talk to them about what happened, what were the triggers behind going and moving from what they're usually doing to what they did to trigger all of these, changes and serious issues that have happened to them, and really use it as a learning opportunity of what can they do differently next time. Because you don't want these patients to feel isolated and to feel like they can't engage in festivities. You want them to actually be able to do that for their quality of life, because dialysis already reduces that, but to do it safely. So then with your own language, you're going to be talking to them about the fact that setbacks are normal, that happen to most people, but you want to make them shorter and not as critical next time when you go out. You want to be able to enjoy yourself without all the negative outcomes that come from it. So that's how we generally deal with some of the relapses or the setbacks that people have. How does that answer your question?
Thank you. Thanks a lot for the tips. I'm hoping the nutritionists that have joined this call, we are about 60 participants with some nutritionists. They probably also take the tips so that we prepare our patients before we go into the festivities. Thank you for that response.
You're welcome.
Just move along. Thank you. I'll just move along to some questions that have been posted in the chat box. There's a participant by the name Sally. He has a question on, I think, is it an issue of information overload? His question is that you have, in your talk, you have discussed an issue about too much information as a shortfall. So please elaborate on how providing too much information becomes a shortfall. Yeah.
So too much information in the one go becomes a shortfall because people will get confused. And once they reach their threshold of what they think they can do differently when they go home, once they reach that threshold, they'll start to get overwhelmed. And we see this a lot with people living with kidney disease, because there's a lot for them to remember. Potassium, phosphate, salt, protein, it's a lot. And so once someone gets overwhelmed, they're actually having a nervous system response inside them where they're getting stressed, and then they're not able to make changes, and they become more forgetful and they become more confused. And so if someone's confused, it makes it harder for them to make decisions about what to do first, what to prioritize. And so instead they end up just avoiding making the decision, because it's easier to not make a decision rather than to make the wrong decision. And so that's how too much information becomes a shortfall. You also, I can see the questions. Do you want me to just go through them? Because I can see them as well. Yeah. So the same person mentioned, I have a patient who has refused to accept that his kidney has issues. He was initiated on dialysis and insists his problem is his kidney is dirty. In stages of change, you talked about most kidney patients being in contemplation. How can I handle such a patient as far as diet counselling is concerned? Doesn't this patient need too much information? Yet you said that too much information is a shortfall. Thank you so much for this question, because there is a bit of an issue here, is that when we are assuming that someone needs information, it's because we think that the problem is a knowledge deficit. But in this situation, it doesn't sound like it's a knowledge deficit. It sounds like there is an issue with accepting that he is unwell, which is very different. So more information is not going to convince him. What actually is going to be more helpful is sitting down and giving the person some time. We've had a lot of these cases as well where I work, and giving a bit more empathy and understanding to his situation. It is really hard to accept that you are in kidney failure if you are one of those people that is not experiencing all the symptoms of kidney failure, because there are some people that are just asymptomatic. And so if you're asymptomatic, what that does is that it reduces your risk perception that anything is wrong. If you have a lower risk perception, you are less likely to want to participate in different health promoting activities. So I wouldn't be surprised if this person might even complain about being on dialysis, might sometimes want to come off a little bit sooner. You're going to see this lack of acceptance across the board. And so this person would most likely be in pre-contemplation, and the way to sit down and help them with the dietary counselling is to empathize with the situation, and to also talk to them about what would it actually take for you to be able to accept that your kidney is not working very well, even though you feel okay, because you're not the only one to experience this. On one hand, it is so great that you're not feeling so sick, but on the other hand, when you're not feeling sick, it means that it's so much harder to accept the condition. And so helping them adjust to what is going on. And then when they're ready, talking to them about, if you knew though, that even just learning about nutrition, learning about diet, not necessarily pushing them to change anything, but just learning about it with you and about the outcomes that it could bring you in 5 or 10 years' time, to still be able to be well. How would that change the way that you feel? And so you ask a few more questions about getting them ready to change before you give the education, because unfortunately, until they accept it, the education is going to be pointless, but you can be a part of helping them build that awareness and that risk perception. So hopefully that answers your question. We have another question around, would you recommend behavioral interventions like cognitive behavioral therapy for patients with recurrent relapses? Yes, you can absolutely use that. And you can, it doesn't have to be in its entirety, but you can use that when you are having conversations. So one very important part is to really be helping people build an awareness around their triggers. And if you were to use the cognitive behavioral therapy model, you'd be asking them about, what was happening beforehand? What were you thinking? What were you feeling? What made you more vulnerable to these behaviors? What made in the past, or when you've experienced this before and you haven't had a setback, you've actually been able to go and enjoy your festivities without getting hyperkalemia or fluid overload. What was different about those times? And then you start to compare with them when they've been able to have better control of things and when they haven't. So they're building their awareness of what's going on as well. The next question is, I have a CKD patient dialysis who has severe GI symptoms with loss of appetite. He has been on vitamin B complex, but still not successful. What can I do to help him? So Victoria, I think with this client, it's this patient's going to be I don't know all of their clinical background, and I'm not sure exactly what resources you have available to you where you work, but really what you can do from a counselling perspective is start asking questions around the severity of the GI symptoms and asking your clients to scale them. So from a scale of 0 to 10, how would you rate your appetite? How would you rate the nausea? How would you rate the vomiting? And keep a very strong scale so you know whether it's going it's improving or not when you do provide interventions, and working out if people are actually scared to eat because they're worried the GI symptoms will get worse. Because if there is a fear behind, I don't want to eat in case I get more nauseous or I'm vomiting, then it doesn't matter what you recommend, what oral nutrition support you might recommend to them, they might not take it if there's a lot of fear. So if you can help to unpack the worries they have about eating more, about trying to push themselves a bit more, and if they were to do anything different, can they do it at the time of the day where the symptoms are not as severe? So if you're able to go through and do a bit of a symptom inventory with them, or when is it worse, when is it better, when can they tolerate more food, when can they tolerate less food, you'll be able to counsel them through that a little bit more effectively, and then work out if they're open to some supplements, or whether they need some more aggressive nutrition therapy. So a question about what causes frequent diarrhea in most CKD patients after consuming green vegetables. People shouldn't really be getting diarrhea after consuming vegetables. Sometimes from the fiber content, people might be having more frequent bowel motions, or they might be a bit softer than usual. But if it's diarrhea, it's probably more indicative of something else, whether they've been constipated in the past and they've had more fiber and there's some overflow diarrhea happening, whether they've also got any maybe gut infections as well that they could have caught. So I would definitely be doing a stool sample for that and just ruling anything more medical out, because the green vegetables really shouldn't be causing it unless they've got some type of intolerance. So yeah, hopefully that's answered your question. And then the next question is, you discouraged using fear to make a patient make a behavioral change. How then can one deal with patients and make them understand who are unable to accept they have kidney disease, since they need to accept and see the problem for them to choose to change? Oh, this is such a great question. Thank you for asking this, because when you are explaining when you're trying to get someone to improve their risk perception, of course, there has to be a conversation around risks and complications. So there is going to be some fear that is going to be evoked in a person. But what you want to do is not just leave it there. You want to be talking to them about how, if they were to change their eating behaviors, things could get a lot better. So it's not about, so you might talk about the risks and the complications, but then when you go to talk about the eating behavior changes, instead of keep to using language around, oh, but it's so you avoid this, it's so you avoid that. If you can switch it over and say, it's so you avoid this complication, so you're able to stay out of hospital more often. So you end up having less hospital admissions, excuse me, for fluid overload. So you end up not needing to have an extra dialysis session to take more water off. You end up not needing to need as much medication or interventions, hospital interventions, to bring your potassium down. So you combine the fear with what changing their eating behaviors is going to help them achieve. And most people are going to want to stay out of hospital and spend as much time with their loved ones as possible. So if you can combine the two, that will be the best, the combination for empowerment. So I think that brings us to the end, or are there more questions in the chat? Do you want me to go through them as well?
Yeah, if you're okay for time. I know it's a bit late on your side, but if
I've
you're
got
okay for
another
time.
10 minutes. Yep, I've got another 10 minutes to stay on, so I'm happy to to go through them. So thank you. Thank you for the lovely feedback. You're very welcome. Carlos, do you know the impact or relation about the frequency and the digestion and nutrition? Would you be able to elaborate a bit on that, Carlos, if you're still here? What do you mean by that question? Okay, feel free to email me and I can answer that for you. The next question is, too much info. My questions are too much. Oh, that got answered. How do we tackle the issue of conflicting information amongst clinicians caring for kidney disease patients? Oh, this is such a good question, and we've been working a lot on this as well within our kidney communities. There's got to be a really good collaboration between anyone that's giving dietary advice, and in the kidney health space, everyone is giving dietary advice. So one thing that I recommend is, if you have a dietitian in your unit, or if you are the dietitian in your unit, start giving in-services and frequent sessions where it's just like either a presentation or a question and answer type of session with your nephrologists and your nurses. Because in my experience, it's actually a very positive thing that we're all talking about nutrition, but we do need to be very consistent and streamlined with what we are communicating. And in my experience too, of taking this approach of giving lots of in-services to both the medical teams and the nursing teams, it means that their knowledge gets to be increased. And you can also have conversations around, well, you know, if you are going to recommend something to a patient, start with this. And if you are from the dietetic department, see if you can share your resources. One thing I did a few years ago that changed a lot of that reduced the conflicting information is I gave all of my resources to the doctors, and I said, when your patients have a problem, give them the resource and send me a referral. So then you're not stuck on memory, because the moment you're not sure about something yourself, because the dietitian is gonna know all of this inside out. It's what they do every single day. But if it's not something that you're 100% sure of, you're more likely to give that advice that might be too strict or might not be so correct. And so give them the information and refer them to the dietitian, and keep a very close relationship within the team so they feel comfortable asking more questions, so everyone's improving their own education in nutrition. Okay, and one more question is, after counselling the patient, do you provide them with a hard or soft copy material? And if yes, would you please share how you design them, so if the patient reads, they can get a clearer picture of what they're supposed to do? Yes, always give follow-up material. One thing that we try to do within our centres is use more of that client roadmap approach that I had put in point number 5, where you might prioritize what they can be doing. And so one of the most popular resources I used to have was an introduction to nutrition and kidney disease. And I would have on one page potassium, the next page phosphate, the next page sodium, fluid, protein. And then I would tick on the front page what they're going to focus on between now and the next session. And I would write down the top 3 things for them to do. So then they're very clear that they can go and read the whole pamphlet, but they don't need to implement the whole pamphlet, because that will keep them it's going to be too confusing. So you give them the information, but you narrow it down for them at the end with what they're going to be doing, and where you can use more pictorials, the better it's going to be. We've had really great feedback with our picture booklets. Okay. Carlos, did you wanna ask me your question again, since you're still on?
I'm here. Because I changed my account to not a panelist, because I didn't call you. So my question is, whole program. I understood all those approach, but for example, in East Africa, we have a lot of problem with patients cannot make more than twice a week dialysis, you know. So and sometimes my view, it's very difficult if the patients not move twice a week, or the frequency change, or the time of the dialysis. Even if they follow the diet, the diet that I can prescribe for him, the body is not prepared to digest, you know, from the food to the nutrition, the body. So that's my question. In our experience, you can see improvement in patients with the same diet when they follow exactly the protocol, international protocol, 3 times a week?
Usually if they can follow the protocol, there is going to be positive outcomes in terms of managing fluid overload and potassium. It is very tricky with phosphate because I'm sure it's very similar for you that you just don't get enough phosphate clearance from dialysis and from the binders that you use. So, and it's very hard to follow a very low phosphate diet, but we do see significant improvements. And what I think has made a very big difference for us in Australia, I'm not sure what for the food supply system is like over there, but we have a lot of phosphate additives in our food. And when you start eliminating those first, you see a really good reduction in their phosphate levels, as long as there's no other issues going on with their bones. You can see very good outcomes with the diet. Yes, we have seen that many times. Where people really struggle and we see their electrolytes being out of control, and they're still following the diet quite well, it's often because there's something going on either with their dialysis clearance, with their dialysis access, and sometimes if they're very constipated as well and their bowels aren't working daily, they'll be retaining more of those electrolytes, because once they become anuric and they're not obviously their bowel system, they tend to excrete more potassium and phosphate from their bowels. So if they're constipated, that system doesn't work.
Okay. Thank you.
You're welcome. Thank you so much for having me. And if anyone's got any other questions, feel free to get in touch. I'd be happy to answer them for you.
Indeed. Thank you, Stephanie. That was indeed quite enlightening. Thank you for also responding to all the questions. And on behalf of Africa Healthcare Network and our panelists, I want to convey my thanks. Hoping to have you again for other future talks, so that we can again learn more about nutrition, especially in CKD or also in the renal sphere, so that again we can impact more lives and we can get better outcomes for our patients. At this juncture, I will just want to invite Dr. Lloyd, if he wants to just say a word before we close. Thank you. Dr. Lloyd? Okay, I think Dr. Lloyd is probably indisposed, so I'll beg to close the session. And again, thank you for making time, and wish you a good evening, Stephanie. And for the other participants, good day. Thank you.
Have a lovely day.